You are not.
Welcome. It is Wednesday, April 23rd. This is the Senate Transportation Committee, and we are here to talk about Medicaid and medical transports in the budget. And specifically, we're here to talk about if the recruitment of drivers and the background checks and all of the issues related to that. And I think we have all of the players in the room. And we had both you, Alex, and Grace on first. So if you wanted to move up to the head of the table.
I think I'm gonna sub in here.
Well, that's awesome.
Okay.
We just need your name and
I'm Ashley Berliner, Director of Medicaid Policy for the Agency of Human Services.
that's awesome. Thank you for coming.
Thank you for having us. Yeah. Boot up my computer here for a second. I'm sorry.
So you have all those details and complications in your head. That's wonderful. It's good to have the medical.
Not stressed at all.
No, but thank you. Seriously, thank you.
Well, Medicaid is a stressful world.
Yeah.
And it's gonna get more so.
Yes. So let me just start by saying I'm the Director of Medicaid Policy. As I said, I oversee the entirety of our 1115 Global Commitment to Health waiver, which is the agreement between the feds and the state of Vermont for how we administer our Medicaid program. And just to set some context for this conversation, I know we're going to deep dive into transportation here, but we are having very concerning conversations with the federal government right now around investigations of fraud, waste, and abuse. That is how they are framing everything. And they are really digging in a way that we've never seen before into our contracts, into our manuals, into our communications using AI to pick up certain word choices. This is a new frontier for Medicaid. And as such, we are paying even more attention than we would under previous administrations to anything that could possibly be perceived as fraud, waste, and abuse by the federal administration. So I just wanted to set the stage for that before I go into my talking points on these particular provisions. Any questions about that before?
No, that's very helpful in helping us think about where we are, because we're all worried about what's going on in Congress and all the cuts in Medicaid that we're talking about and all of the different pieces.
It's extremely concerning. So we have been here now twice before.
Yep.
Thank you for the opportunity to come once again. When we came previously, we really focused on federal and state requirements related to background checks, and appreciate the committee and the Agency of Transportation and BPTA's participation in making changes to the language to satisfy the requirements of the Medicaid program. Today, I'm really going to focus testimony on language located in section 27, and then briefly in section 29. So section 27 requires DVHA to provide detailed analysis of a proposed non-emergency medical transportation contract to the Joint Fiscal Committee for review and approval prior to executing the contract. Each of the sub-bullets in section 27 are of concern to the Medicaid program. I'll take them one at a time, and please feel free to interrupt me at any point. So sub-bullet 1, it specifically references the older adults and persons with disability program. DVHA is not the appropriate entity to examine the older adults and persons with disability program and consider anything related to OND when it's procuring its NEMT program contract. CMS goes so far as to specifically prohibit consideration of other programs beyond Medicaid or the sustainability of a public transportation system when contracting for NEMT. They've opined specifically as other states have delved into this arena.
Can you, that's really important to us in many ways. So if you could just maybe send us something or send us a report,
Yes, thank
because
you.
that's very critical.
Thank you for the prompt. What I'm going to talk about today is super weedy, and I am not the subject matter expert to get into those weeds. And we have our general counsel intimately involved in the contracting of NEMT services. So we're going to follow up very shortly after this testimony in writing that will provide you with all the citations you're looking for and a lot more robust detail around our concerns.
So there's two things that you cannot consider. And can you just say it again?
Well, we cannot consider anything beyond the scope of NEMT for Medicaid. So if you told us to consider school buses, we wouldn't be able to consider that. But we certainly, the things addressed in this bill are O&D and the sustainability and affordability of the public transportation system. And we cannot consider specifically either of those things.
Okay.
And that's pretty clearly spelled out in federal regulation that cannot be considered when contracting. And again, going back to that fraud, waste, and abuse lens that we're really under right now, I'd say more of a microscope. That's something we're paying particularly close attention to and are pretty concerned and being, I think, appropriately conservative. So that's sub-bullet 1. Sub-bullet 2, A2, requires DVHA to prove that there will be no degradation of services to eligible individuals. First, I'll say it is always Medicaid's goal to ensure that members receive high quality and timely care. That is a core part of our mission. But this provision reads that DVHA must also ensure that there will be no degradation of services to O&D, which is outside of the scope of the NEMT program. And it is not something that we can have within our request for funding proposal or contract for NEMT. Section 27A3 requires DVHA to ensure that the NEMT contract will not impact the financial stability of the state public transportation system. Again, this provision puts DVHA in direct conflict with federal law. It doesn't permit us to consider anything related to financial stability of the public transportation system. And DVHA cannot consider any factors other than the needs of the NEMT program when procuring a vendor. Section 27B requires DVHA to complete an analysis of the impact of a new NEMT contract on the Agency of Transportation's investment in vehicles and technology. This is outside the scope of the Medicaid program, and if the committee desires this analysis, it should be directed at the Agency of Transportation. DVHA is just not appropriate or equipped to provide this type of analysis. If the legislature is asking for a report and not trying to influence the contract itself, then I think having that conversation with the Agency of Transportation is what we would suggest.
So do you have metrics that you could share as, you know, going forward, and probably metrics that you use now just to measure the system
In terms of access, the number of rides, and
the things that are important to you?
yes.
Okay. And are those shareable?
Yes, though I will say, and I should have said this at the beginning, we know that we have problems with our NEMT system, and we are in fact we have outside contractors working with us right now to really dig in and improve our provider manual, but also to help us think about a Medicaid member manual to make it clearer to both providers and Medicaid members what our NEMT benefit is. So as we go through that, we're also thinking about what data are we collecting and how are we measuring outcomes. And so what we have now is very much current state and not the goal where we're trying to get to really in short order. And certainly by the time we have a new vendor selection for NEMT.
So that's within the year.
Yes.
Okay. So that'd be great if you can share that. Thank you.
Okay, so section 27 as written without language carving out specifically that NEMT services must meet only and primarily the needs of the Medicaid program, subvert federal law here. And DEVA and AHS request that this section be removed. I also want to point out that Section 27 requires DEVA to prove that any new contractor beyond BPTA can meet expectations far beyond those required of an NEMT provider. And what it's functionally doing is enshrining into law a preference for current contract and the status quo incumbent vendor. That's how we're interpreting it. And it is why we feel that this section is so problematic.
So the whole section.
Yes.
Of 27.
27.
Yes.
We will get into it in writing in the follow-up
Yep.
written testimony, but just to say again, there is specific law that talks about open and competitive bidding and a prohibition on conflict of interest. And there is also state law in Bulletin 3.5 that explicitly says that their process should not include any bidder that is favored over others or the perception that a bidder is favored over others.
Yes.
So that's 27. I know that was a lot of information to pack into that one little section.
We need to know.
And then we've had problems with 29.
29 requires DEVA to publicly outreach for to do publicity and outreach for BPTA's current volunteer driver program, which creates the perception, we believe, that we're improving the quality of their bid in advance of them bidding on an RFP.
Where is the
Section 29.
right, but which part of it?
It's the part around publicity and outreach. Let me pull up my program screen.
Maybe just the third line, but communicating with the Vermont driving public.
So there's
Well,
Oh, no, that's.
we
yeah.
do ask for
Yeah.
notice of public outreach placed on the department's website and other. Here's the fine line that comes up for me. There's a line between calling it outreach and stating and giving examples of eligibility. You have a better handle on eligibility for the program than any of the rest of it, and we all depend on you for that. So how do we make sure that the information gets out based upon eligibility? And public outreach may not be the term to be used, but it's a line. If the public transit agencies or the agency of transportation has a question about eligibility, they're going to turn to you.
Yeah. So
where in this is the line? What is the terminology that should be used? And because the crux of this problem comes up to that piece.
So again, we acknowledge that there's room for improvement and are actively working to get better communication out to members. Totally on the same page that needs to be better. Where the concern comes in is that this is broader than just the Medicaid program, the current language. And so we absolutely can commit and are committed to getting communication around eligibility for NEMT. The problem lies in any communication on O&D, which we have no jurisdiction over and cannot provide any Medicaid resources to support.
Okay. Well, we'll look to see if we can't refine language. And as I said, our council won't be here for another 10 minutes, but we're going to have to work on how we do that. You know, it's a fine line here between public outreach and how we communicate to people you might be eligible for something.
And I want to certainly offer to the committee, if you're interested, that we can take a pass at language too, and we can get you something today. I know you're in a rush, so if that's of interest.
Well, we're not in, my goal is that by the time we leave for the weekend, that we have an idea of language and have people comfortable with that.
Okay, so we can definitely get back to you today with some language there. And also just to say, it sounds really harsh when we as the Medicaid program and the state government are like, we can't deal with this other part of state government. But again, just to bring it back to the context that we're living under, it feels particularly risky right now in this federal administration to be doing anything in literally in writing and federal law that, or in state law, that would conflict with what's in federal law. So we're just paying very close
If you would
attention to that.
just, since Senator Perchlik wasn't here, if you could repeat what you said in the beginning about not audit's not the right word, but review that you're going through with the feds around. So if you could just
Yes.
quickly repeat that.
Absolutely. So, and I was providing context related to the federal landscape and what's happening in the news and what we're feeling on the ground with the Centers for Medicare and Medicaid Services and the federal government at large, as they have this heightened focus on fraud, waste, and abuse. That's how they're couching pretty much all of their proposed Medicaid cuts as fraud, waste, and abuse. And they are specifically going into any sort of state documents, manuals, contracts, RFPs that relate to federal funds. They're using AI to keyword search. They are very much in our business in a way that they never have been before, with this particular lens of how do we cut dollars from states under the guise of fraud, waste, and abuse. It's a much more liberal interpretation of fraud, waste, and abuse than I think anyone in the Medicaid program has ever used before. And so that's the lens that we're coming at when we're looking at this language, to be conservative and to make sure that we are really in clear compliance with federal laws as it relates to any of our contracting and administration of Medicaid.
Okay.
But do you need language for?
We're they're going to provide us with the first draft. We'll have Damien take a look at it. We're going to hear from Jim Moultons on the from the public transit agencies, and anybody else that's can articulate to you what their needs are, because there's frustration within the community. And as we try to get more drivers, this is one of the barriers to that. So get it all out and see if we can't get something that everybody can agree to here in a way to move ahead. Part of the issue for DEVA is our language talks in 29 about public outreach, and they don't want to be seen as advertising for but there's a fine line between advertising and articulating to people what that might be eligible. Are you eligible or not?
Sure.
My small world. The village closest to me is Jeffersonville. There's a small place called Nan's Meadow, and there are 22 apartments with elderly people. And the church that my partner, she belongs to, they all the time give each other rides, but they're always desperate to find rides for the 90-year-old. How would you the content of the poster that I can envision being put up there, the content would have to come from you. You know, the pieces of you would be eligible for. The public transit agency might put it up, but the content has to come from you. And how do you articulate it in a way so these elderly people understand what they might be eligible for?
Yes, understood. And I think we can definitely do better in that respect. And we really appreciate the changes to section 28. We're planning to work with AOT and BPTA around communication and around just volunteer drivers in general. So I think we have some good action steps to improve the situation on the ground today.
But from beginning to end, from the recruitment of drivers and all of that to what do the public transit agencies, what does the agency of transportation, what are they able to say has to come from you. And there's a public outreach level to this. We don't want to get DEVA in trouble with the public outreach, but you're the content people.
Yes, understood.
The chair, so is the idea is if there's agreement on the language that there would be a floor amendment detail or?
Exactly.
Okay.
You know, and this committee would put together a floor amendment as a technical correction to this to get it. We were under some pressure from the appropriations chair to get our bill over to appropriations by last Friday. So not every little detail was exactly done.
That's appreciated.
Do you know the chair of appropriations?
Yeah.
Do you look at him every morning? Thank you. So if you can, are you done with 29?
Yes.
Just one more
Sure,
question.
absolutely.
Just, so the other part of this system, right, is the provider, the medical provider. So I would think we're gonna look at outreach there too.
Yep.
I mean, we should have, to the extent that we're gonna have posters or something, we should have it in the provider's office too. So I'm sure you have a good communication with or I would hope, with the providers, medical providers, right? So are you seeing that as part of this system? Or do we need to find another way to coordinate with them?
I don't think you need to find another way to coordinate with them. It's really part of this wholesale rethinking of our manuals and how we're defining NEMT for providers, but also for our members. And from that's where we're really going to clarify everything in our policy. From that, we will be able to have offshoots of communication as appropriate.
Okay, so we'll rely on DEVA to,
Well, I
or maybe, I don't know, I just
think
wanted,
what we're going to rely on is all of you coming together, the public transit, you know, to discuss and you each have your own individual piece to work out, but there has to be some overall communication in this between all of you.
Yes, and I'm very much hearing what you're saying, Chair. So when we propose that language, we will be keeping that in mind, that coordination, and we'll write it in a way that clarifies Medicaid's role specifically, but as a participant in a broader conversation.
And I'll say this because there are people here that are representing more the hospital piece about this. What we hear from the public transit agencies is the way appointments get set up, that there's no coordination. Is there an ability where people can bundle somehow appointments for people that are going to ask for rides, and they take two people in a car? Is that a possibility? We don't know if it's a possibility or not, but that's a discussion between the hospitals, the doctor's offices, public transit agencies. And is that permissible under the rules, or would that be prohibited by any of the regulations through this. I think those are the kind of things that we look for you all to sit down and discuss. Thank you.
Yeah, please.
So the question is Anthony here? Anthony, you look like you're next on.
Morning. Anthony Knox. I'm the Blueprint Program Manager for the Randolph Health Service area out of Gifford Healthcare. So in particular, I know we were just talking about as far as trying to coordinate appointments and transportation in relation to that. So one of the roles within the Blueprint team is to help those individuals who are struggling with transportation to be able to get to medical appointments. So one of the things that we do primarily try to do is not only are we helping coordinate the actual transportation itself, but we may also be trying to coordinate the medical appointment for that individual as well. So one of the things that we really strive to do is that, okay, if you need to come in for a primary care visit and then you need to go upstairs to a cardiology visit, we definitely try to coordinate multiple appointments at the same time and, have it blocked that the patient may be there for 2 or 3 hours just based on the appointments and availability, and then have somebody pick them up after the fact. Traditionally, we haven't done a lot around multiple people coming in for similar appointments. Potential issues around HIPAA and people may also not feel great about riding with somebody who is maybe suffering from the flu and they're just going in for their annual physical. So, there are some, considerations that have to be thought of, in relation to that. But from my team's perspective in particular, we do strive to be as efficient as possible with getting people to appointments and things like that. The challenge we run into is that a primary care visit being available at 8 o'clock in the morning, and then there isn't a cardiology appointment available for 3 days later. So now we have to coordinate doing 2 separate rides for the one individual. And yes, we would reach out to that public transportation company to get both of them set up at the same time, but with the understanding that it's going to be, potentially days apart just based on availability. So that is definitely a big challenge that we face in relation to that. And then of course it doesn't help when there aren't people to do the rides. Maybe the specialist is only available on Thursdays, and that's the one day that there's no volunteers to transport and things like that. So, there may also be situations where we have to schedule them at the HMC, which is now a much longer ride for somebody who lives in Randolph, and thus the volunteer is now out of service for an even longer period of time in relation to that. So, from the actual scheduling of appointments and trying to coordinate, for specific patients, we are trying to combine as many appointments as we can in a similar day. But as far as multiple people going to different appointments and trying to coordinate that's not necessarily something we have totally looked into for a variety of reasons, in particular, just, HIPAA concerns around, different medical conditions and things like that. So.
Your information is really, really helpful. Mm-hmm. So what proportion of patients or rides, or however you want to term it, are you able to make happen?
I know when I came up and spoke a couple weeks ago, there are transportation challenges that our patients are facing. It's roughly 1 in 5 patients are having some form of transportation challenges. And I would say a majority of them are to be able to get to medical appointments. Yes, a lot of them, it's, being able to engage in other social engagements or to be able to go grocery shopping or run errands and things like that. But there's, again, I don't have a specific number, so it would be,
Or just,
but I would say from my team's perspective, and I have 5 or 6 people that their primary job is to help coordinate transportation to and from medical appointments.
wow,
I would say we have, there's at least, 1 or 2 a week from each of them that they're trying to arrange transportation to and from Gifford, or not just Gifford Hospital, but to any of the ancillary clinics that we have in Rochester, Chelsea, Berlin, and Bethel. So
there's 5 to 6 people who are who have that job.
that's part of their job.
So
Yes.
that's interesting to know that. So transportation is obviously a thing. So are you able to find rides for everyone? It sounds like you generally are.
So it may be, we may have to work with the primary care office or the specialty office to reschedule an appointment because there
Okay.
is no transportation that day, which then puts a delay potentially in the care that they need to receive because of that, because, and we very much struggle with the inability to do a same day appointment. We struggle with doing an appointment first thing in the morning or very end of the day. So it really ends up having to be, middle of the day, which, there tends to be, cancellations at the end of the day, and things have been able to be shifted around. So we could, potentially somebody could come in for a 4:30 appointment, but there's nobody there's no volunteers, there's no staff or anything like that can do that transportation, at such a late hour at that point. But again, we struggle with doing anything same day, and traditionally it seems like we need to average, at least 3 or 4 days out of an appointment to ensure that individual can actually get to their appointment on schedule.
So the timeliness is.
Yes.
And do you just use the public transit folks or the Medicaid provider?
Yeah.
Which are the transit folks?
Yeah, so I mean,
Points,
we would call Tri-Valley Transit, or we'd call, Green Mountain Transit. Those are the 2 biggest transit companies, at least within our service area, to be able to provide transportation.
Okay, so you're lucky you have 2 actually.
Yeah.
And so there aren't other folks who would do transit.
Not that we've had any, success with. I mean, we do try as much as we can. Do you have a family member who could transport you especially at a late notice? I mean, our team also does find out that, there's this cancellation, is there any chance that you could make it in? And, we do try calling the transit company, but then, we'd also talk with the patient as far as, can your spouse drive you? Can your daughter drive you? Whatever the case may be, which tends to be unsuccessful in that late, spur of the moment type of appointment.
Okay. And then just one other question, this might not be for you, but does the hospital subsidize or help pay for the transit at all?
Ashley?
So I'm Ashley Lincoln. I work at Gifford as well. In the past, Gifford has provided financial support to our local transportation company, Tri-Valley Transit. That was general, operating support.
In the past?
And I can't speak to whether or not that's been able to happen in this fiscal
Okay,
year.
so they may be still doing it.
I don't know if we're able to do that in this fiscal year.
Oh, it's,
Can you
I think I understand what you're saying.
you said that what the dollar amount was about? Like, your rent?
And I know Jim is on here as well and can correct me. I believe that our gift was, I think it was $10,000, but again, that's not something, was that right, Jim? Yes,
Okay.
it's not, and I'm pretty certain we will not be doing that.
Okay, thank you.
Okay. Any other questions or?
This has been very helpful. Thank you.
Great, thank you.
Did you want to add on?
The only
to-
thing that I will add is that another challenge we have is weekends. So oftentimes we do have a Saturday clinic where we try to support those acute walk-in needs. And there is no transportation on a weekend. And so that is when you would then look at a very expensive appointment in the ER that would require an ambulance transport.
It'd be great to have the Like what it costs to have ambulance transport versus service on Saturday.
Yeah, I
And
think
just-
actually in talking about language coming around this, maybe one of the things we ought to add into the discussion as you all sit down and talk about this is that very issue.
Mhm.
Do you need notes?
I guess.
Okay. Jeez.
Sorry.
No, you're not. You're busy. But as we all talk about that, let's try to remember that in peace. Jim,
Thank you, Chairman Westman. Thank you all for having me again to talk about these important issues. For the record, I'm Jim Moulton. I am the Executive Director of Tri-Valley Transit, serving Addison, Orange, and Northern Windsor counties. And I'm also the Chair of the Board of the Vermont Public Transportation Association, VPTA. You heard a lot of information this morning, which, if nothing else, illustrates the incredible complexity of trying to provide transportation for our folks in Vermont who are the neediest for medical services. Both the testimonies that you heard before speak to the challenges that we face in trying to provide these services. So I'm open to whatever specific questions that the committee might have. I can speak a little bit more at large about the challenges. If nothing else, even the conflict between the testimony around non-emergency medical transportation for Medicaid, Ashley spoke about fraud, waste, and abuse, and we have a lot of efforts going into providing the most cost-effective service possible. One of the big elements that we have been in discussions with and working with DEVA over the past year is more coordinated transportation, putting more people in any particular vehicle to keep the cost down. You just heard from Anthony that type of coordination might compromise HIPAA. Just an example of the different elements, different pressures that we face in trying to provide cost-efficient and effective transportation. So again, I'm open to any and every question, but or can continue as your desire.
go ahead.
Hi, Jim. Thanks for being here. I'm so glad we're having this conversation. Is it like who? I'm thinking the senior housing places are obviously places that we should focus on, I would say. And at some point, because the individual ride is so expensive, and because people, even if they aren't missing appointments, they're having to redo appointments. And so medical care would be improved if we could get people to appointments on a regular basis. Have we looked at a fixed route that would focus on senior living or senior housing and just model that? Or who, I don't know if V-Trans can model something like that, or if we would need FABO. But I just think that's something that we should look at, because there could be, within a 20-mile radius around a hospital, there could be a very logical fixed route. In Brattleboro, actually, or Windham County, we were talking at one point years ago, and we still could do it, about a fixed route between two hospitals, because that happens a lot, that where hospitals, that's where doctors are, just doctors that you see not in an emergency. And those two hospitals were interested in helping to pay for that service. And so if you had a regular fixed route that went, from 7 in the morning till 6 at night, maybe, it might end up being less expensive than this other system for certain areas. We would still want the individual system for areas farther out, but I would just like it if we could model that.
If I may, Senator,
Yeah.
I would say, one of the longest standing services that all the transit providers put out there are fixed route services. Many of the hospitals, if not all the hospitals around the state, do have some level of fixed route service. Typically, it's not that end of the system that's the challenge. It's how far out can a fixed route system go to collect people and as they get more and more rural and more isolated. And there's a cost effectiveness element to that as well. So typically it's been a blend of services. The fixed route services often are deviated fixed route services, which also allow them to go somewhat off the beaten path to pick people up. But it's a blend of those services with the dial-a-ride services, often illustrated by the volunteer driver system. So that's not to say that additional study or modeling or anything of any services might not be appropriate. It's more to say that what we have found over the years is that it has to be a blend of those services. One thing that I would also like to just make sure that is clear for the committee from VPTA. First of all, we incredibly appreciate all the effort that you have put into trying to help us provide a better medical transportation system. The effort behind the sections in the T-bill are all clear that you're looking to make sure we can do the job. I also want to be clear that we are not looking to subvert anything like safety of the riders or federal regulations. We absolutely understand the importance of federal regulations. We are, from my perspective, one of the more highly regulated industries in the government, whether it's under the FTA for the transit elements or under CMS for the medical elements. So we absolutely hear what Diva is saying in terms of making sure that the language doesn't cross any federal rules and regulations. But we also are consistently looking for how can we get more resources to make sure that we are able to provide the transportation that we can and to do it cost effectively. I'll just briefly go back to, I was really struck by the fact that we have these expectations of cost effectiveness illustrated by trying to coordinate rides when those come in conflict with HIPAA requirements. It makes it very, very challenging.
Any more questions for Jim? Thank you, Jim.
You're welcome. Thank you so much.
So is there anybody else that would like to comment? What we will be looking for is some language from Diva. We're going to circulate that language with you and you, Jim, and with you for the blueprint. And Damien's going to be the coordinator of this. Our goal in this committee is to have language that by Friday that we can look at and make sure that everybody, the players involved with this are comfortable. And if we can get to that language, I think it's the intent of this committee of having an amendment on the T-bill on the floor and to replace those sections. But we want all of you comfortable with the language and the ability to move ahead.
Mr. Chair.
Good.
I was just gonna say, I have those sections pulled out in a separate document. If while you were working on the language, you would appreciate a Word copy that you can mark up, please just email me and I will send you the Word copy and then you can mark it up and send it back. And then I can circulate it to everyone else.
And I think what we heard from Diva is they're going to take a crack at further language and they're going to get that to you. And then if you could make sure that Jim and the rest of the people in the room get a copy so they can.
All right. And does Megan have everyone's email addresses? Because I know I don't.
I do.
Okay, great. I'll coordinate with Megan to make sure I can get everyone emailed. And then if you need a copy, just shoot me an email or Megan if you don't have my email. And I will make sure you get a copy of the Word document. So you can-
And for the committee and everything, the plan is that the T-bill for second reading would be up on the floor on Tuesday. So that gives us the ability to make any adjustments we need to. I think this is the main area that we might make adjustments in the bill. And if we can have that by Friday, we can vote on it. So we're ready to go on Tuesday morning when we come back. But
Great, so this is not a question about the bill process, but just about funding, just because I think we should know. There's, well, it's either the O&D or the Medicaid, but there's a certain funding source that sometimes is limited so that folks can only have like 5 rides a month. And it depends on how much funding we have. Is that, can any of you speak to that?
It's not Medicaid.
Okay, so it might be the O&D then.
Jim has his hand up.
Okay.
Thank you. Yes, Senator Harrison, the O&D program has a certain amount of funding available to it. And within each region prioritizes with community members and community stakeholders what the priorities for transportation are. Typically, dialysis, cancer treatment, things like that are at the top, but that often leads to there are specific limitations to how many more rides can be provided. I will say the demand for rides far exceeds the amount of available funding. We are likely to run a deficit in the O&D program this year that we're currently in due to the level of demand, even though we do provide those fairly onerous limits to the number of rides that people can have. It's a very challenging environment that we're operating in.
Okay, I just want us to know that funding is still a challenge and this is not Medicaid, it's other funding. That's limiting rides to medical services. Okay, thanks.
So at this point, I think we're going to, we come to an end and we'll look for language, Damien, and circle it back around. For the committee, I'm going to, there is going to be some language in the appropriations bill. And I'm going to let Senator Perchlik talk about the plan is for the funding of the positions that of the recruiters within this area. So
Appropriations looking at amending both, like adding to the appropriations bill, or amending the T-bill when it comes in to do a little money switch the system. So it would, I don't know if you remember the line in the T fund appropriation for non-federal emergency municipal support. I forgot what's called. What's it called?
You're talking about the non-federal disaster.
Yeah, non-federal disaster program. I don't know what it's called, but basically the $1.1 million, I think. That's appropriated. I think they appropriate money into that every year. Some years they need it, some years they don't. I think so far I asked for some information on how much money is spent. The only thing I've gotten is from 2024. I think they spent $250,000. So this is when there's a very localized, microburst or something that caused the culvert to wash out and the road needs to be opened, and small rural towns, the state could come in and help them make sure that could just fix it quickly so the road can be open. So it would be only for municipal roads, not class 4 roads. So roads that need to be open for travel. We're not going to get into people trails. So instead of using P fund for that, take money from the pilot funds, the payment in lieu of taxes. That fund has money in it. And since it's going to municipalities, this is money that the municipalities pay to the pilot program. We would put that money into the T fund that frees up that 1.1 million of T fund dollars, 600,000 of which would be used for this non-medical transport recruitment program. And then it also frees up money for the T fund, the deficit and like the revisions and things that they would define.
And would that be recurring funding? Do you anticipate?
It would, the money that would go in there would be only used for there, so the AOT couldn't say like, oh, there wasn't a disaster, let's use it to pave East Overshoes Road. So they couldn't do that. They could only be used for non-medical, non-federal disaster work on roads. So it'd stay there if there isn't a disaster, but whether new money would be put in would be a question every year.
Well, and I think because we're in the last year of the contract before they have to go out to bid for this service to be provided, I think the hope would be we would have a better idea of how much of this is maybe Medicaid related. So if the recruitment effort is going to an agency that, for example, 40% of their patient load is Medicaid, is there some ability to draw down Medicaid dollars to continue this? And we'll have a better idea after the first year.
I like diversification of revenue for sure.
So that, I don't think the idea is to get this started and not continue.
And it helps the T fund with $400,000 that frees up, which is small in the whole context of the T fund, but it's something. And then it helps with the whole volunteer writing stuff that we're talking about, which helps reduce pressure on the T fund for all that.
So that's the language that will be floating here and in
So
appropriations.
yeah, so we'll bring it to the transportation committee to get the transportation committee's support of that.
Because the pilot fund has, because there's also that. I'll talk to you about
Yeah,
that.
if there are other requests.
Pilot,
funding,
yeah.
We have some other things in the budget, and then my understanding is that Damian and Logan have language for both of those amendments, so we could probably have them, but some notice to present that language.
Yeah, so I've sent the language to parentification at this point, so your committee assistant should have it.
Okay.
And I think I'm scheduled for tomorrow afternoon to present it.
In appropriation.
Yes,
Yeah.
and appropriations, and then if you approve it, I can bring it back here and present it at the right time.
Good.
We would like to have transportation support.
Well, and will that be an appropriation amendment to the T-bill, or however you want to do it, we're fine with that. We could always have it presented in here, and could we do an amendment on medical transports? We could do that too, as kind of a, and it would be our adjustment
Yeah,
after the fact.
because we have it in the budget, so we don't need to, I'm pretty sure the language that Damian said got added to the language. So if not, we do that today. But then, yeah, we could do the actual language. Yeah.
We're totally open to however you want to.
Maybe, yeah. Maybe it's easier to do it as one amendment that both committees support.
Okay. So just, so we all have an idea of where we're planning on that and everything.
Thank you.
So we're going to break now. And, if we could be back here about 11:15, we have, I thought this would be a good time to get an update on where maintenance is, and after the winter we've had, how close they are within their budget. But at 15:15, I am going to have copies of, Damian did a section by section of brief, and we'll break up the sections for people to look at as what they will report at that. And we thank everybody for coming, and